So, ladies and gentlemen, good evening. This day from the news special session organized from SOI, we have an outstanding guest today, Mr. Professor Bornfeld as a speaker. He's a distinguished consultant ophthalmologist with subspecialty expertise in ocular oncology and vitreoretinal surgery and retinal diseases. He obtained his medical license on 1977 and completed specialist training in ophthalmology by 1981. I wasn't born. Now, 1984, he further specialized in vitreoretinal disorders and intraocular tumors. He was appointed professor at the Free University of Berlin at Charité, and he contributed there to launch the ocular oncology unit, and he also performed his vitreoretinal surgery there. From 1997 to 2017, he served as a director of the Department of Posterior Segment Diseases at the University Hospital in Essen, and continued as a director of the department till 2018. Under his leadership in Essen, Eye Clinic became a leading international center for the management of ocular tumors, particularly retinoblastoma and uveal melanoma. His research and clinical expertise contributed to reform the guidelines in the tumor therapy. He is widely recognized for his expertise in the management of intraocular tumors and complex retinal conditions, and he right now still a researcher at the University of Essen, Duisburg, and a widely international speaker at national and international congresses. Thank you very much, Professor, to accept our invitation, and thank you. And we are very proud to allow ourselves to welcome you today. You have the talk, please.
Thank you. It's a privilege for me. Do you understand me? Is the audio okay?
Yes.
Is the audio okay? Yeah, okay. And of course, it was my greatest privilege to have Dr. Rahal as a senior surgeon in our department. There was no one better. And so it's my privilege today to take part today. So I would focus on this session on pediatric ocular tumors. Most of the time will be spent, of course, on retinoblastoma, and I will address. I'm not alone. You're never alone when you're doing ocular oncology. These are my colleagues who allowed me to use their results and present the results. You know, walk along, of course, if you do pediatric ocular tumors. So what are the topics? The topics, of course, the main topic is retinoblastoma, and I would like to focus on diagnosis, on modern chemotherapy of retinoblastoma, on some aspects of proton radiation, and a very exciting new topic, as I feel, is liquid biopsy, and I would like to address shortly socioeconomic aspects, because I feel these are really important, and it's what we have to focus on in the next years. So diagnosis. You probably all know that leukocoria is a leading symptom in 50% of all retinoblastomas. And leukocoria can be detected very easily. You just need a lamp, nothing else. And you have to be careful to look in both eyes from different directions. You may think that the child on this screen may just have leukocoria in the left eye. But if you just walk along and around the child and child looks in other directions, that is definitely leukocoria in both eyes. So it's essential to spend some time on doing this examination, which is basically very simple, and to be sure that the child, which is not very cooperative when you look into the eyes with a bright light source, that the child is looking in different directions, so you can be sure there's leukocoria in one eye or in two eyes. Most of the detection of leukocoria is done with the family photos. This is such a family photo of a child with leukocoria, and if you just look into the eyes, the patient notice that there's a white pupil on the right side, and this is a very frequent history for patients with a retinoblastoma that parents detect on family photos that there's leukocoria in one eye, and then they just see the ophthalmologist or pediatrician. Modern digital cameras have negative impact on this because they correct the wet reflex in both eyes, and so they correct leukocoria as well, and it disappears in modern digital cameras. So this is, from the perspective of a pediatric oncologist, a disadvantage. What are the basic diagnostic measures if you have a suspected retinoblastoma? These are very basic. You do not need very much equipment or anything else. Everywhere, in medicine, medical history is very important, and this includes the examinations of both parents. I will show you an image later in the talk why this is important. Then an examination under anesthesia is essential. If you have a patient with leukocoria, made retinoblastoma, made congenital cataract, made anything else, examination under anesthesia is essential. Otherwise, you will miss very important findings, and you will miss small tumors, you will miss anything. So in anesthesia, biomarcoscopy, ophthalmoscopy, and ultrasound, very basic examinations, but you need anesthesia. The child is not very cooperative. In most of the patients who have a retinoblastoma, you will probably do an MR imaging, never do a CT. You will find in older textbooks that you should do a CT in order to detect calcification in the tumor. You don't need that. And don't do it because it's radiation exposure to the child. Don't use CT, use an MRT, and that's complete. That's okay. Do not do intraocular biopsy. This is different from liquid biopsy, and I will address liquid biopsy later in my talk. But intraocular biopsy with getting tissue from the eye is totally forbidden. You have a high risk of disseminating tumor cells in the orbit elsewhere, and never do it. It has a high risk of dissemination of tumor cells, and that has a very bad prognosis. Why is it essential to look at the patients? Patients may have what is called a spontaneously regressing retinoblastoma or retinoma, and from the genetic point of view, from the genetic perspective, that's the same as a retinoblastoma. So you may see patients who have a retinoma and have children with retinoblastoma and just are not aware of having a tumor in the eyes. So examination of both patients, both parents of the patient is essential. Just normal ophthalmoscopy to find out. And if you see tumor like that, a retinoma, this is probably hereditary retinoblastoma. You're probably all aware on the genetics of retinoblastoma. There are non-hereditary retinoblastomas and hereditary retinoblastomas. In non-hereditary retinoblastomas, somatic cells is okay, and the two mutations needed to disable the retinoblastoma gene are somatic mutations. So not all body cells are involved, and that patient, as a rule, has a unilateral retinoblastoma. In hereditary retinoblastoma, body cells are affected, and the first mutation from the two alleles everybody of us had in our genes has already happened. It's a germinal mutation, and then the second mutation occurs, and as a rule, and there are exceptions, as a rule, these patients have bilateral retinoblastoma, and there are exceptions of these rules. And you should not consider that if you see a patient with an isolated unilateral retinoblastoma, that all these patients are not hereditary. A large percentage of 13% of these patients have hereditary retinoblastoma. And so it's essential if you, for example, do removal of the eye, all is essential to get the tumor tissue, to do a genetic evaluation of the tumor tissue and find out what the mutation in the tumor is, and to differentiate between the unilateral hereditary retinoblastoma and the non-hereditary retinoblastoma, which of course has a very high impact on further children and on the patient itself. Retinoblastoma was one of the first genes having been sequenced. And that was because it was very well known where the deletion probably was located. And that is why patients, it's because patients who have a cytogenetic deletion in chromosome 13 have a very specific specific way where they look, And if patients have a major cytogenetic deletions in chromosome 13q, that's a locational retinoblastoma gene, they have a very specific look. And the girl on the second row from the left, the second from the left, this is totally typical. And so if you're used to it and work in the center with retinoblastoma, the anesthesia coming the patient in, just look at the patient, that is a child with retinoblastoma. So it was very well known that patients with cytogenetic deletions in chromosome 13q have a retinoblastoma. And so it was very easy to look where the gene was located, and retinoblastoma was the first, or among the first genes ever been sequenced for malignant tumors. And this is more than 25 years ago. Yeah. So what are the stages of development of retinoblastoma? And if you just look at this fundus image, you see a very shallow tumor, just superior and nasal to the optic disc. And probably you will feel that if you look at a patient who doesn't like ophthalmologist at an age of 2 months or 3 months, you will miss that finding. So it's essential, again, as I said at the beginning of my talk, it's essential to have an examination under anesthesia to find out these small, shallow tumors, which are the initial stage of retinoblastoma. Larger tumors probably will not be missed. If you look at a patient with dilated pupil, it's essential to have a dilated pupil. And if the progress of if the disease progresses, you will find large tumors, multifocal tumors, tumors invading the vitreous body with vitreous seeding and complete seeding into the eye. The Lausanne group has published an excellent classification of these different stages. And this is the stage where there's an endophytic vitreous seeding is occurring. And this is shown here, that results that the tumor is infiltrating endophytic into the vitreous. And this is shown in this picture. And this endophytic vitreous seeding may cause pseudo-multifocal growth, excuse me. And this may be originally a unilateral tumor or unifocal tumor. And by seeding into the vitreous and multiple growth, it looks like a multifocal tumor, but from the beginning it was a unilateral unifocal tumor. So it may be in the case, it's very hard to detect on this between these different stages. Retrohyaloid sealing may occur. And so the seeding is behind the posterior hyaloid membrane, as seen in these images. And an exophytic subretinal spread may occur. And so this results in total retinal detachment if it lasts long enough, as is shown on the image on your right. And these patients may be confused with patients having a total retinal detachment. Of course, these patients have a total retinal detachment, but the cause of this retinal detachment is not retinal break or trauma or anything else. It's a retinoblastoma. And if you look in particular at the patient on the left, you see that in some areas of the retina, there are some whitish infiltrations. And that always should make you very suspicious if you see a retinal detachment with whitish infiltration of the retina. That looks very much like a retinoblastoma. On the right side, you see some tumor behind the retina. And again, that should make you very suspicious, but it may be very difficult to differentiate these patients from Coats disease. And I will address this topic, Coats disease, retinoblastoma, later in my talk. There are 2 ways where the retinoblastoma may leave the eye. One way is choroidal invasion, and this is very frequent in large tumors, as shown on the left. You see that the patient has a very broad, deep infiltration of the choroid, and so it may get access to the blood system. And on the right is what, of course, every ophthalmologist fears, is that the patient, that a tumor is invading the optic disc. What you see is a prelaminal and a post-laminal infiltration of the tumor. So the tumor has extended through the lamina cribosa and may get access to the subarachnoidal space. And that, of course, is a very worse outcome or very worse progression, as then there's a risk of systemic spread of the tumor within the central nervous system. And I will show you later some very unhappy patients having that late stage of retinoblastoma later in my talk. What is really intriguing is to diagnose diffuse infiltrating retinoblastoma. And this may be mistaken for any other diagnosis. And the most frequent misdiagnosis of these patients is having an endophthalmitis. And what you see on this image are just whitish infiltrations of the vitreous body, and you will, in some of these patients, never see an intraocular mass. There's no calcification, there is no intraocular mass, there's no intraocular tumor. There's only these diffuse infiltrating retinoblastoma strands in the vitreous, and these may be very hard to detect and to diagnose, and maybe, as I said, be confused with an endophthalmitis. This is not an endophthalmitis, and you might be addressed, or you might be irritated if you see the patients having these white nodules in the anterior chamber. This is what is called a pseudohypopyon. And again, it may be mistaken for an intraocular inflammation, but these are seedings of the tumor cells on the iris. And it looks like a hypopyon, but it is not. It's a pseudohypopyon, and it's caused by retinoblastoma cells invading the anterior segment diffusely. And you see that on the histological image of the same patient, where you see that the tumor is invading the ciliary body diffusely. It's invading ciliary processes, and this is very, very bad, or the diagnosis of this tumor is maybe very challenging. So I'm showing you some other cases. That is a patient who has a pseudohypopyon with seeding of tumor cells in the anterior chamber. And the same patient 4 weeks later, if you just look at the patient, you see that what may be considered to be an hypopyon. But if you look at the iris, the upper iris, you see tumor infiltrations in the upper iris. And so this is not a hypopyon. It's definitely seeding of a tumor cell. Another patient who started with other patients seeding of tumor cells in the anterior chamber. The right eye, of course, is a very advanced stage of pseudohypopyon or retinoblastoma. This, as I said, is a very challenging diagnosis. This is a patient who had a subluxation of the lens. And our first diagnosis was better child syndrome. Better child syndrome typically has luxation of the lens. And so we saw the patient again, and so it's maybe better child syndrome, and it was not. It was a diffuse infiltrating retinoblastoma, which is seen on the images in the lower, the two lower images. Better, it's diffuse infiltrating retinoblastoma, infiltrating the zonule, and leading to dislocation of the lens. Again, it's a challenging diagnosis. Another case with diffuse infiltrating retinoblastoma with pseudohypopyon, showing you the infiltration of the tumor in the eye on an MR imaging. And I stop with diffuse infiltrating retinoblastoma in a minute. But it's sometimes really scaring to see patients like this very unhappy 4-week-old girl. That patient was in the pediatric department because of vomiting and weight loss. And nobody checked the intraocular pressure. And the intraocular pressure of this patient was 50 millimeters of mercury because of a diffuse infiltrating retinoblastoma, which caused high intraocular pressure and all the other symptoms. That may be present at birth. There is just a child after birth, immediately after birth, and what you see is an advanced chemosis. That is a view of that eye with chemosis. And some of these patients are treated with cortisone, and that works. That is a patient who was treated with cortisone. Again, it's the MR imaging of this patient. And that patient was treated with systemic corticosteroid therapy for 10 days. And that was much better, of course, but the tumor still was there, of course. And you always have to look what is the source of such chemosis at the time of birth. And retinoblastoma may be present at birth, which is uncommon, but it occurs. Another unhappy patient with a very advanced retinoblastoma with infiltration of the whole eye, chemosis of the orbit, and of course these patients have a high risk of diffuse metastasis and have at least bad prognosis. As I said, retinoblastoma may invade the optic nerve, and this is a very unhappy patient from the Ukraine who it took a year to come to our department. And so it was a very advanced spontaneous cause of retinoblastoma, both eyes with infiltration of the optic nerve. And these two eyes were approached ophthalmologically, surgical, and with a neurosurgeon. And what you see on your right is a very uncommon view of an optic nerve. You're looking on the optic nerve from the other side of the orbit. So you're looking from the brain's perspective to the orbit. And what you see there is the optic nerve infiltrated by the retinoblastoma in the optic canal. And our approach was to get that optic nerve as complete as possible out of the optic canal, not to leave any tumor tissue. And this shows you the infiltration of the optic nerve with a retinoblastoma. And of course, it's a very unusual view of an optic nerve for an ophthalmologist. I just surely would like to address what is called a trilateral retinoblastoma. Trilateral retinoblastomas may occur in about 2 to 3% of all hereditary retinoblastomas, in hereditary retinoblastomas, not in non-hereditary retinoblastomas. And these are midline tumors with a rosette formation, very similar to the histology of a retinoblastoma. And prior to 1995, there were no survivors. It wasn't detected, and it couldn't be treated. And now, with better detection techniques, with MR imaging, and what we all have now available, the availability of systemic chemotherapy in these patients and stereotactic radiation, survival rate is much better. And the consequence is that in cases of hereditary retinoblastoma, these patients must be followed to find out midline tumor, which is called trilateral retinoblastoma, very early. And if this is found very early and hasn't seeded into the leptomeninx, the survival of these patients is quite good, but it has to be, of course, as all these tumors, detected early. How are retinoblastomas classified? There are two classifications, and what is widely used by all the centers is what is called an international classification for retinoblastoma. There are different versions, unluckily, different versions of this classification, and this is what is used in Philadelphia, but they're basically very similar. And it starts with A. These are intraretinal tumors, less than 3 millimeter thickness, which are not involving the macula, the optic disc, and it goes on with stage B. These are all other intraretinal tumors, not invading the vitreous. Stage C are tumors with focal, subretinal, or vitreal seeds, with focal, not diffuse. Diffuse subretinal and vitreal seeds are typical for group D. And group E are all the catastrophes you may see in an untreated patient with retinoblastomas, tumors filling half of the globe, neovascular coma, hemorrhage into the anterior chamber, vitreous seeding, postlaminar invasion of the optic nerve, scleral or anterior chamber. And it may be interpreted as enucleation with E. And of course, most of these patients probably have no chance to keep their eyes with at least some function. There's another classification, which is from the American Joint Committee on Cancer Classification, TNM. And just recently, there has been a paper just looking at these two different classifications, and they have pretty much a very similar predictive value. And the metastasis-free survival rates and overall survival rates are comparable between all these schemes. And it may be better stratified with the AGCC classification, but it's not widely used. Most of the centers use the ECRB classification, as shown on the last slide, and we'll see what happens. What are the pseudoretinostomas? And I have just to change my screen. Just a minute. I have to push Dr. Rahal a bit to the side. I hope he doesn't. He isn't too much concerned, but he doesn't see it probably. So, what are the pseudoretinostomas? Some years ago, we had a study in Essen, and we looked at 31 non-functional eyes, blind eyes, which had been removed, and where we have some experience in doing retinoblastoma diagnosis, where we were unable to have a final diagnosis. We were unable to rule out retinoblastomas. What did we find in these eyes? That was one too much. 6 of these eyes, which is a large proportion, had retinoblastoma. And the others had the typical differential diagnosis, including Coats disease, astrocytomas, retinal dysplasias, and Medulloepithelioma. And I will address Medulloepithelioma later in my talk a bit more in detail. And we'll just show you some of these cases, not too much statistics. And if you just look at these two different images, you all may have a personal guess what is a Coats disease and what is retinoblastoma. And I would tell you, right is Coats disease and left is retinoblastoma, and vice versa, probably you will believe it. You will see cases in patients where you are unable to find out with conventional methods. Liquid biopsy will be addressed later in the talk, where you will be unable to find out it's a retinoblastoma or is it Coats disease. And some years ago, there has a publication from the Vancouver group on a patient where very massive vitreoretinal surgery was planned with a diagnosis of Coats disease. So surgery was planned to do a 360 degrees retinotomy, remove all subretinal exudates, vesicle in the eye, remove the lens, put the lens in. Oh, luckily, it didn't happen because that patient had retinoblastoma, and you probably could assume what would have happened if that patient was treated in this very courageous way. So always be aware it may be a retinoblastoma, and if you do intraocular surgery in a retinoblastoma cases, this is a catastrophe. That is a histological image of the same patient with retinoblastoma. So what's Coats disease? Very shortly, Coats disease is a disease of young boys. It's in nearly all cases unilateral, very rare, extremely rare, this bilateral. And the main symptoms are very much the same as in retinoblastoma. These are leukocoria, strabismus, and loss of visual acuity. The clinical features are very typical in early cases, not in late cases. Microaneurysms, capillary ectasia, capillary occlusions, and exudates. And as a rule, there are no systemic comorbidities with one exception. This is, I don't read it out, FSHD1, very rare muscular dystrophy. I haven't seen just one patient in my career, so it happens, but extremely rare. How does it look? This is a fluorescein angiogram of a patient, and what's typical is that the vascular malformations are not in the center, but in the periphery. So if you see a patient with anything pathological in the center of the retina, always look in the periphery. And if it's Coats disease, you will find the source of whatever you find at the posterior pole in the periphery of the retina. This is shown in this image with an extensive exudation in the periphery of the retina and some still normal posterior pole. And you may see other patients, and you may see some patients who have centrally or close vascular abnormalities located close to the fovea. But that's rare. Most of the patients have normal foveal structures and normal vessels at the posterior pole, but have all the pathology in the retinal vessels in the periphery. That again is a patient with a very advanced Coats disease. That's a left patient. That is the left image gewesen. That was the left image in my previous slide. So it was Coats disease. Again, a patient with an advanced Coats disease, and you may see some vascular abnormalities in these patients, but that could be as well a retinoblastoma, and sometimes you're unsure. The visual prognosis of Coats disease is limited by the occurrence of subfoveal nodules, shown in this patient. And again, you see in the fluorescein angiogram, the vascular pathology is located in the periphery, not at the posterior pole, not the primary vascular abnormality. There are very few other tumors. And at the end of my talk, hopefully there's time left to address Medulloepithelioma. And one of the pseudo-retinoblastomas which may occur but are very rare are solitary pilocytic astrocytomas. These are tumors which typically invade the optic nerve, and they are clinically indistinguishable from retinoblastoma. They look like a retinoblastoma. You have no chance to find out whether this is an astrocytoma or retinoblastoma. Most of these patients have very advanced tumors, as in this patient. So these eyes are functionally blind. So you have to move the eye in order to find out what tumor it is, and the function of these eyes, as a rule, is lost. So these eyes should be enucleated, not to have the risk to not detect a retinoblastoma, which was misinterpreted as astrocytoma. You cannot distinguish between an astrocytoma and a retinoblastoma from the clinical point of view. Another frequent pseudoretinoblastoma is what is now called persistent fetal vasculature. These are typical findings with an anterior and a posterior persisting fetal vasculature is seen in these two images. as a rule, these differential diagnoses can be made as a rule quite easily. So what are the modern treatment techniques? And I just would like to focus with respect to the time we have for this talk to the modern techniques in chemotherapy, which now are used in most of the patients we see, and would like to address a special of Essen, as we have the proton radiation facility that in very advanced, very special, very selected cases, proton treatment may be considered in the treatment of retinoblastoma. So why chemotherapy? And the traditional treatment technique for retinoblastoma was external beam radiotherapy for years, starting in the 60s. And this is a very effective treatment. And local control of retinoblastoma with external beam radiotherapy is excellent. So why change? And all the centers, years after they started that type of treatment, found that there was an unacceptable high rate of secondary malignant tumors. And these are the patients with the red and the orange line, external beam radiotherapy and external beam radiotherapy is chemotherapy. And you see that these patients have a very high risk to die of secondary malignant non-ocular tumors. And you see on the right a very unhappy patient with a very quick, rapid growing soft tissue sarcoma starting from the treatment field which was used to treat the retinoblastoma, the radiation field which was used to treat the retinoblastoma. And these patients have an extremely bad prognosis. So starting with 2006, 2005, there were some older papers from Japan. Nobody looked at it, and then the treatment was reinvented. And starting with 2004, 5, 6, the focus was on what is called super selective intra-arterial chemotherapy. In intra-arterial chemotherapy, a catheter is placed into the ophthalmic artery, which is really a tricky procedure, and these are very small children. And so a regional treatment of the eye with melphalan as a rule is done. You see the schematic drawing on your left, and you see a real patient on your right, what is called a blush, to be sure that the catheter is positioned correctly into the ophthalmic artery. And you see, I think in a spectacular way, the vascular system of the eye and the orbit. And once you know that the catheter is placed correctly into the ophthalmic artery, and then the drug is injected, which is a rule is 3 to 5 milligram melphalan. This is a very effective treatment, and I will show you some of the patients have been treated with this technique. That is the patient with a large retinoblastoma treated with 3 sessions of intra-arterial chemotherapy and a complete regression of the tumor, and that is appearance of the fundus after finishing the treatment. I just have to change my... Just a minute. Okay. And that is a patient 1 year after finishing the treatment. And this is another patient with a very advanced retinoblastoma treated with intra-arterial chemotherapy. And that is a patient where we and other centers experience that this is treatment, of course, not without complications. And that patient got a compartment syndrome of his lower leg after the second intra-arterial chemotherapy. The catheter is placed from the femoral artery and up to the ophthalmic artery. And that patient got an occlusion of the femoral artery, got a compartment syndrome of his leg, and we were very frightened that that patient may lose his leg. Luckily, he didn't. Was treated as compartment treatments are usually treated with large incisions, and the patient and the leg survived. But it shows you that that treatment technique is effective, but is not without complications. So that has good luck and good outcome. There are some minor complications which are not very important. On the left side, you see a blush of the forehead, which shows you, which is really a picture for the anatomy and the vascular supply of the head. And on the right, You see loss of hairs in the midline, which is due to the meningeal artery, which may be included in the chemotherapy involuntarily, and these patients lose hair. But of course, is not important if the eye is rescued. But it shows you that there's a treatment which may have complications, and that is a patient has a femoral artery occlusion at the site where the catheter was placed in order to come to reach the ophthalmic artery. This revascularized, but this is a complicated treatment. Another complications of intra-arterial chemotherapy is complete arterial occlusion. This is a patient who had a retinal necrosis with secondary proliferative retinopathy. The only eye of this patient gewesen Monday after an uneventful intra-arterial melphalan treatment, and it shows you an occlusion of the central artery, incomplete probably, and large retinal edemas, and it has, of course, a regressive tumor, but a choroidal necrosis and proliferative retinopathy after that, and unfortunately, a complete loss of vision. Luckily, this is always rare, and we should be aware that these are patients who have no other treatment option. And some years ago, we published the results in Essen. Of course, there's no more experience, and it will be published the next time on the current results and treatment with intra-arterial chemotherapy in Essen. And in these very advanced cases, 68% of these eyes could be preserved, which is, of course, is a very good result, but there are complications. There are complications in about 40% of the patients. You have seen some of these patients with severe sight-threatening complications and non-visually threatening toxic reactions. You have seen the patient with the occlusion of the femoral artery and a compartment syndrome. So it's a very effective treatment, but we should be aware it is a treatment technique with potential very severe complications. Just recently, the New York group has published their results. That's David Abramson, who has really pioneered this treatment. They published very good results. They published that they salvaged 75% of the group of the eyes in groups D and group E. I'm a bit shaky, and such a high success rate may be possible in group E eyes, and with focal treatment techniques, of course, it cannot be done. And 61% of naive E eyes were salvaged. Yeah, it's good. Maybe it's better than all the rest of the world. And a meta-analysis from Chinese center showed that the odds ratio, so the chance to preserve a globe compared to inoculation when intra-arterial chemotherapy is used, was more than 2.4, which is a very good result. So the chance to salvage an eye, which has no other choice than inoculation, is quite good. But again, as I said, this is a very treatment technique which may have a lot of very severe complications. The recent advances in chemotherapy are focused on intravitreal chemotherapy. Intravitreal chemotherapy is done for stage C and D eyes, and technically the approach is to have a paracentesis and to do liquid biopsy of the aspirate. I'll go on some of the aspects of liquid biopsy later in my talk. Then an intravitreal injection at a distance of 2 millimeters from the limbus is done using either melphalan or topotecan. Topotecan is more and more in the focus of interest now. It started with melphalan, and most centers now are switching to topotecan. I will show you later why most centers do that, and you do a triple freeze cryo at the injection site. And they had all the centers, when it started, had been very reluctant to do that type of treatment because, as I said, everybody was very afraid that if you open an eye with an Norbert you may have seeding of tumor cells. But now we know from now thousands of patients treated that way. If you just look at the cumulative statistics published from the Global Retinoblastoma Initiative, the risk of getting, there is no risk of getting tumor cell seeding if you do that in a technique as shown here. And so it's now a standard technique in treating retinoblastomas, and it has a definite advantage of getting an anterior chamber aspirate and process that aspirate for liquid biopsy, and I'll show you liquid biopsy later. This is such a patient who had systemic therapy, who had double brachytherapy, had cryotherapy, and he got a recurrence of the tumor as shown here by the arrow. And intravitreal chemotherapy is the only option that patient has. And that was done with triple intravitreal melphalan injection. The tumor is completely gone. There is another patient with intensive advanced vitreous seeding of retinoblastoma. This is the same patient after 9 intravitreal injections and brachytherapy of the primary tumor with a very good results and regression of the tumor. And as you see here, after the first sessions of injecting melphalan into the vitreous. Yeah, there's another patient with vit seeding, and that patient was treated again with 9 intravitreal injections and brachytherapy of the initial tumor with complete regression of the tumor and complete remission of the intravitreal seeding. So intravitreal chemotherapy, of course, has no systemic complications. All these complications you have seen with intra-arterial chemotherapy, of course, are not present. And just recently, there was a comparative study of 64 Asian Indian institutes and eye centers, and they found complete resolution of the vitreous seedings. In most of the patients, more than 90% in melphalan and topotecan, the difference was not significant. And the focus is more and more now on topotecan, as topotecan is probably higher effective. And the main advantage of topotecan is it is less toxic. Melphalan injected into the eye has toxic effects. And of course, it's toxic if it's in high concentration in the retina. You always will find correlated scarring at the injection site, which is peripheral. But the incidence of complications related to the toxicity of the drug are less in topotecan, as shown in the last row of this slide. Retinal pigmented epithelial atrophy, optic atrophy, vascular attenuation, and hemorrhages are less frequent in topotecan. And so most of the centers are now focusing on topotecan and high-dose topotecan. And probably in the next years, this will be the drug of choice in treating intravitreal treatment of retinoblastoma. And this probably is a very good option in the next years to further improve the treatment of retinoblastomas. Just a very short word on retinoblastoma. I'm looking to on my clock. And as I said in the beginning of my talk, radiation treatment has an unacceptable high rate of secondary malignant extraocular tumors, so it is not done. But the advantage of proton treatment is that you can spare off the bony orbit. How is it done? It is done, as you probably know, with an immobilization of the head, and we are using 2 tantalum clips. We have a proton radiation facility in Essen, so we are lucky to have access to this facility. And the advantage is that you can spare off the bony orbit, so you do not deliver any radiation dose to the nasal sinuses and not to the bony orbit. And that is a patient, a very unhappy patient with a recurrence after systemic therapy, after intra-arterial chemotherapy, and he had no further intra-arterial chemotherapy option. It was the only eye, and it's a functional eye. You see posterior pole is looking quite normal, and that patient was treated, one of our first patients we treated with protons. This is a radiation plan for proton treatment, and you see that you can create a radiation field which you cannot create by any other method, and which nearly spares off the bony orbit and totally spares off the nasal sinuses. Again, that's a lateral view, and you see what the advantage of such a proton treatment field is. And that was very effective in that patient. 2 months later, it was complete remission of this recurrent tumor. There's another patient with a recurrence after intra-arterial chemotherapy and no other option with intra-arterial chemotherapy. And then again, this patient was treated with proton treatment. That is the same patient 6 months later. This is an exceptional treatment. It's not a routine treatment, and it's reserved just for patients who have no other options. And we have published that some years ago in the first 10 eyes. And these were all very unlucky, hopeless cases. And we were successful, at least, to keep more than half of these patients with an acceptable visual acuity. But this is a treatment which is reserved to very selected cases and far away from being a routine treatment. And metastasis occurred in these very advanced cases. So just a short one on liquid biopsy. What is liquid biopsy? Liquid biopsy is the sampling of non-solid biological tissue, in particular blood, and for an ophthalmologist, aqueous humor, vitreous aspirates. And what you can detect are circulating free DNA. And this can be examined with which is called now next generation sequencing. You can detect circulating free microRNA and circulating tumor cells. And so you have a chance to detect RB1 mutations. And what you can detect further genetic parameters like somatic chromosomal copy number alterations, SCNAs. And now that we're doing more and more intravitreal chemotherapy, and that we now more and more have aspiration of the aqueous humor, when doing intravitreal chemotherapy, we can perform that. This is schematic drawing showing what can be done. Left the technique on getting the aspirate. And what you can do is sequencing, next generation sequencing. This is B on this graph, and you can do SCNAs, copy number operations, and MYC gene alterations. And that turns, and you then just doing on the aspirate, you can establish the diagnosis of retinoblastoma. This has been published by the San Francisco group, which were pioneers in this method. And they have done a prospective study on liquid biopsy of the aqueous humor, and they were successful in isolation of tumor-derived cell-free DNA. You see here, they could detect sequence for cyclid nucleotide variant analysis for the RB1 genes and SCNAs. And we now know that we have a good chance to detect Coats disease and retinoblastoma. When you find in aqueous humor mutations for RB1 gene, it's not Coats disease, it's retinoblastoma. And these could be detected with a very high success rate in this series. And SCNAs were detectable in 2/3 of the patients. And we now know that these SCNAs and other genetic parameters like the MYC gene alterations have a great impact on the therapeutic outcomes. And it looks, the recent advantages and developments are that probably the treatment technique and the treatment protocol may be adjusted on these genetic findings, and that is another excellent option in the future for further improvement of retinoblastoma treatment. Very shortly on socioeconomic aspects. I feel that we, at least in Western countries, have some responsibility to be active in that field. And there's a global retinoblastoma study group, and Didi Fabian in London, who's very active in this field, has shown that there are very big differences in the results of treating retinoblastoma in the world. And he looked at treatment-naive patients with a retinoblastoma within the study. There are a lot of studies, I will show you some. And he looked at patients residing in 40 European countries and patients in 43 African countries. And the capture rate to get these patients was 42.2% for expected patients in Africa, and it's more as 100%, which sounds unlogic, but all patients not having retinoblastoma were included from Europe. So living in Europe, as well in the USA, or in Canada, or in a country with developed systems, you have a good chance to have an early detection of the retinoblastoma, and this is shown by the catchment areas on the left. And you see that Europe is completely covered by the catchment areas of all the retinoblastoma centers in Europe, and it's a very bad situation in most of Africa. And that has an impact, and I will show you that in some slides, that has to be improved. Patients living in some areas of Africa do not have a chance to see an ophthalmologist within an acceptable time frame. And that results in patients like this. These are patients we have seen or have been contacted for an advanced retinoblastoma from Nigeria, Laos, and Angela. And these are patients who, I had been in Nigeria seeing these patients, and it's a mess if you see patients just having such advanced stages of retinoblastomas because it couldn't reach an eye doctor. And this is a very unhappy patient we have seen from Ecuador with a very advanced retinoblastoma that has been treated in a very inacceptable way. Thus, the tumor was resected in the eye, and what you see is a very advanced retinoblastoma with the infiltration of the brain and seeding of the tumor cells in the spinal cord. And that patient, of course, had no chance to survive the tumor, and that very unlucky girl died of that tumor. This global retinoblastoma study group has looked at the socioeconomic status of these patients. LEC means low-income countries, low-medium-income countries, and high-income countries. And you see that the death rate and the inoculation rate is correlated to the incomes. So if you're living in a high-income rate, the deaths are 1% of these patients, and the patient is living in a low-income country. It's a fourth of the patients, more than 25 or 28% of these patients die because of retinostomas, and just 1% of the patients living in Europe or USA or everywhere else. There's shown again in another statistic just recently published from the Global Retinostoma Study Group, and it shows here the Kaplan-Meier analysis for survival with low, mid, upper, mid, and high income rates, and there's a big difference. And high income rates have an excellent survival, and if you have a low income rate, the survival is bad of these patients. And this is shown in the lag time interval between first symptoms and seeing an eye doctor. And you see that the patients have 12 months time interval to see an eye doctor. They have a very bad prognosis. And of course, that can be changed. That is again from the retinoblastoma study group, just recently published, showing the incidence. The incidence is different in all countries of the world. You may read in all textbooks that in all countries of the world, the incidence of retinoblastoma is the same. That's not true. The incidence is higher in some in some countries. It increases in countries where the first and second generation survives and get children with retinoblastoma. So in Europe, the incidence of retinoblastoma increases because there are survivors of retinoblastoma. Anyway, you see the incidence of retinoblastoma on this world map. And if you just look on the death rate, and just go back and forth on these two slides, you see that it's really a mess. In Africa, it's a mess. In Central Asia, it's something which shouldn't be tolerated. And that just some years ago in Lancet published on survival and global preservation in the world. And what you see, Central Africa is a mess. It's better in the States and in Europe, of course, but there are a lot of countries, including India, Indonesia, where the survival rate is very bad. And there are things a lot to do. So, but the conclusion for socioeconomic factors, these have a huge impact on morbidity and mortality in treatment of blastoma, but we can change it. There are steps that can be taken to address this, and we all should do this. And I'm doing, hopefully, help that this may be changed, and the patient living in a low-income country is not dead because it doesn't see an eye doctor. We have 7 minutes, and I would like to address medulloepithelioma at the end of my talk. Medulloepithelioma is a rare tumor, and probably it's most misdiagnosed intraocular tumor in childhood. So what are medulloepitheliomas? These are unilateral, non-hereditary tumors arising from the primitive medulloepithelium. That's why they name medulloepithelioma. And they are mostly in the area of the ciliary body. So these are all tumors in the anterior segment of the eye. Medulloepithelioma never starts at the posterior pole. So when you see such a tumor, a white tumor sitting somewhere on the ciliary body, dislocating the lens, you should be aware that this may be a medulloepithelioma. These are children between 2 and 10 years of age, not too much different from retinostomas. And the vitreous seeding is extremely rare. I will show you a case of this. Medulloepitheliomas are classified as teratoid, containing heteroplastic elements, and non-teratoid with medullary epithelial elements, and they are further subclassified as benign or malignant. This is a very benign medulloepithelioma with cartilage and other heteroplastic elements, as you see here, but it was a tumor which was growing across the optical axis of the eye within weeks, but it was non-malignant, as you see in this histological slide. Some of the misdiagnoses in medulloepithelioma is ophthalmos. And this is such a malignant medulloepithelioma which has been treated with diagnosis of ophthalmos multiply. There have been multiple treatments because of diagnosis or with a suspected diagnosis of ophthalmos. And so medulloepitheliomas may be occult in very early stages, and they may initially manifest with secondary complications, lens changes, glaucoma, uveitis, and they may be associated with DICER1 gene mutation but that's rare. This is another patient who has been treated with multiple treatments, including an Ahmed valve, glaucoma valve, with a diagnosis of ophthalmos. And maybe very late, the ophthalmologist noticed that there was a whitish mass behind the lens in this eye, and it turned out to be malignant epithelioma. And some of these patients are treated with a suspected diagnosis of congenital cataract. If you see at the MR image, look at the MR image at the left, you see the lens is missing, and that patient had undergone cataract surgery. And when the eye was removed, the surgeon noticed that there was a whitish mass behind the lens, is seen on your right, and that was a medulloepithelioma. Medulloepitheliomas may occur or manifest as masquerade syndromes. And this is a very, very interesting case. That was a 10-year-old boy who had the first symptoms of papilledema, diffuse vitreous infiltration, sentinel serous choroiditis, and he was treated systemically with intravitreal methotrexate, and systemically there was diffuse thickening of the retina at the posterior pole. And then months later, there was a mass in the ciliary body, a massive uveitis, a retinal whitish opacities in the vitreous, as seen here, and pretty much was seeding, and that patient then had loss of vision. Vision was defective light perception, the eye was removed, and it turned out to be a malignant medulloepithelioma with a retinal infiltration. That tumor had enough time to invade the whole eye and was invaded into the retina, malignant. This is rare, but it just may be a case to remember that medulloepitheliomas may manifest as masquerade syndromes, and you should always be aware when you see such a patient that this may be a medulloepithelioma. There is another patient who had an intraocular drop metastasis. This is a medulloepithelioma arising from the ciliary body, dropped off to the posterior pole, and that's going there as a vascular tumor on the posterior pole of the retina. So what are the therapeutic options? Most of these patients probably will have enucleation because most of these patients are seen in a very advanced case. You may perform local resection with partial lamellar sclerouvectomy. Tumors may be treated with cryotherapy, which is not very successful. External beam radiotherapy shouldn't be done, although it's published in the literature. But plaque radiotherapy, brachytherapy is a good option in these patients. That has been published in the Indian group from Kalki years ago, and we have published that last year. Our patients with local radiation of medulloepithelioma and chemotherapy is very rare. That has been successful, well, it has been published just in one case. So probably the best option in treating medulloepithelioma, if you have the option of doing eye salvaging treatment modality, is brachytherapy. This is one of the cases from Essen, with medulloepithelioma invading the anterior chamber. That's MR imaging on your right, and that patient was treated with brachytherapy with a complete regression of the tumor. You see the indentation of the lens, which has been caused by the tumor, and the tumor is completely gone, and that eye was salvaged. So what the summary, hopefully, of my talk is that the modern focal chemotherapy for retinoblastoma have improved significantly, and the salvage rate with a good functional rate have improved significantly with local and intra-arterial chemotherapy. And local intravitreal therapy is really booming, I would like to say. Proton treatment is an option for exceptional cases. It's cases who have no other option in the eye that has at least some functional prognosis. Liquid biopsy will improve diagnosis and prognostication in retinoblastoma, and probably will change the treatment protocols for retinoblastoma in the next years significantly and improve it even more. And clinical diagnosis for medulloepithelioma is often failed, and it should always be considered in cases, as I've shown you, with masquerade syndrome, but enucleation is not the only option in these patients. Some of these eyes may be salvaged with local brachytherapy as a most preferred treatment option for medulloepithelioma. Thank you very much for listening to me. I hope we are in the time. Yes, we are.
Thank you very much, Mr. Professor, for this very worthwhile, informative talk. We have right now Professor Ibrahim El-Nawais is the head of retinoblastoma unit in Jordan, and
Yeah.
like to have a comment.
Yeah.
Professor Ibrahim?
Can you hear me?
Yeah.
But we don't see you.
Okay. So it's nice meeting you again, Professor Bornfeld.
Yeah.
I have a question to you. I have encountered few patients with retinoblastoma which developed over the course of the treatment rhegmatogenous retinal detachment.
Yeah.
What would you do in those cases?
We have published on that. If there's a long time interval, we have a paper published on that, on treating retinal detachment after retinoblastoma treatment, or intraocular surgery after retinoblastoma treatment, including vitreoretinal surgery. If there's a long time period between treatment and retinal detachment, maybe years, I think it's not very much of a problem. I personally have seen only just one case where probably an active tumor was in the eye. All the others had just rhegmatogenous retinal detachment because retinal breaks occurred at the large calcificated masses in the eye, which may be a source for retinal break. So if there's large time interval between years, between retinal detachment and retinoblastoma treatment, probably you would just proceed as you would do in any other case of pediatric retinal detachment. If the tumor treatment has been recently, I would be very shaky. And then you have real risk to have vitreoretinal surgery in a patient who has a vital intraocular retinoblastoma. We have published some of these cases some years ago, and these are all a mess.
Okay.
So depends on the
Actually,
time interval, yeah.
if the time allows, we have a good experience with external buckling without drainage in 6 cases, and we had excellent outcome. I think the most important issue: don't open these globes, because then you will have metastasis all over the eye.
Sure.
The last question, if you allow, I have seen that you have treated Group B patients with intra-arterial chemotherapy, and as you mentioned correctly, intra-arterial chemotherapy, I think in our hands it's reserved for stage D. E, I don't know if we have a chance, but for Group B, we have excellent success rate, more than 90% with systemic chemotherapy and focal therapy. And as you mentioned, in Group, if you with intra-arterial chemotherapy for Group B, sometimes you might encounter unhappy complications like the one you mentioned, but we have also in around 3% of our cases stroke. Did you encounter that?
Yeah. Luckily, we had no stroke, but there are deaths and fatal outcomes after intra-arterial. Patients have died after intra-arterial chemotherapy. Luckily, we haven't seen such a patient, but there are strokes. After you are totally right.
Thank you very much. Thank you.
But topotecan is a game changer. There's some euphoria that topotecan may be used in high dose and is less toxic than melphalan, and probably, if that turns out to be true, and there are more and more publications, Eva Biewold here from Essen will publish now a paper on topotecan in intravitreal, and probably will further reduce intra-arterial chemotherapy. I'm not so euphoric as David, but of course, he's a great man in retinoblastoma, David Abramson, but he's very euphoric on intra-arterial chemotherapy, and that's not our perspective. No.
Thank you.
We have some questions from the room. Miss Professor Arwa Al-Adm is the head of retinoblastoma unit at the University Hospital in Essen. She has a question. Does the high percentage of devastating complications of IAC justify its use?
The current perspective is that more and more patients will be treated intravitreally and less intra-arterial. If it turns out that topotecan is so effective and definitely much less toxic than melphalan, I think the game changer will be intravitreal topotecan. This is what's on the horizon. And if that turns out to be true, intra-arterial chemotherapy probably will be less. It needs high equipment. It's radiation to the child. I didn't address that. But you have a lot of radiation to the child if you do that procedure. And you don't want to do that with no child, and definitely not with a retinoblastoma child. There's another severe disadvantage, which I didn't address in my talk. And it all can be It's not important if you use intravitreal chemotherapy. I think topical intravitreal will be a game changer. Yeah.
So thank you very much. That means for me, you will prefer to let IAC for
reserved for less cases, for reserved cases.
For
Yeah.
workers.
Yeah.
Okay, thank you.
Yeah.
Another question from Professor Arwa. If a child is born with bilateral acquired phthisicial eyes and diffuse dense vitreous opacities and small few calcifications obscuring fundus details, how can we rule out spontaneously regressed retinoblastoma? Should the eye be inoculated, or we can consider it as spontaneously regressed and do not need an inoculation?
That's one of the first items I learned from my teacher, which was Professor Höpping. And the first thing he told us was, if you have a patient with an eye that's blind, you don't know the diagnosis, get the eye out. And he was right. Yeah.
That was the study from Miss Schluter, I think.
Yeah.
Yes.
Yeah, the study from other studies.
Similar
He's not
cases.
the only one. Yeah.
Yes.
Yeah. You have experience. If you see retinoblastoma every week and every day, if you're experienced, you will miss retinoblastoma.
Yes. Thank you.
Yeah.
Another question from Mr. Rifai. Thank you very much for the valuable talk. His question, do you think it's necessary to include RB1 genetic testing in premarital screening? It's very expensive.
Yeah, it's a problem of legacy, of judiciary. It's different in different countries, and probably makes sense if the mutation is known. And what is now allowed in Germany, but was not allowed, is pre-implantation diagnostics, which makes sense. But it's very different in different countries in the world. I don't know how it's done in Arabic countries. It's different, but doing genetic testing per se is very effective. And if you have one of the parents has retinoblastoma, hereditary retinoblastoma, pre-implantation diagnosis rules out to have a child with retinoblastoma. And that has been illegal in this country until 5 or 6 years ago. And now it's legal. You can do that. But probably it may be different in Syria. Definitely it will be different in one of the Asian countries. It's very liberal in China. And so it depends very locally. But just from the medical perspective, at least if you have a parent has retinoblastoma, pre-implantation diagnostic makes sense. You will have healthy children even if you have a retinoblastoma. Yeah.
It's has an ethical ground.
Yeah.
Another question, Mr. Professor, how can we exclude retinoblastoma in babies with pre-septal cellulitis? He asked about CT imaging. CT
No CT. No CT
in children.
Never CT in child. Never CT in a child.
CT, but which imaging do you prefer here? Or we need imaging absolutely.
MR imaging. Yeah.
Yes,
but you should never do a CT in a child. Even if you're not a retinoblastoma, there's very basic, very good statistics that these childs have a high incidence of brain tumors. Any other thing, you never should do a CT in a child if there's no other option. No.
Sure. So when then we should use MRI here in such case if we are skeptic? We
are using it very frequently.
Yes.
And could have shown you some images. And if you use a surface coil, not the standard MR imaging of a head, but the surface coil, just making images of the orbit, these are excellent images now. And I think MR imaging is the gold standard. And that can be repeated. Children have no problem getting anesthesia. Forget it until they're adult. But there's no side effect, and MR imaging, in particular, if you use a surface coil, these are excellent images now. The best, better than any ultrasound. Yeah.
Yes, thank you very much. Another question. Thank you for such informative lecture. Please, can you give us key points to diagnose Coats disease compared with or to differentiate from retinoblastoma?
One of the key ones is bilateral. If you have a bilateral if you have bilateral symptoms, this is probably not a Coats disease. Coats disease are unilateral. It's very interesting why is Coats disease unilateral, not bilateral. Then there have been books written on that topic, but Coats disease is unilateral. So unilateral, bilateral is a topic. And it's very early, it can be detected. You just do an angiogram and you will find typical Coats lesions in the periphery, then you have probably the diagnosis. If it's very advanced, as shown in some of the cases I've shown in my talk, you will not make the diagnosis safe. And liquid biopsy is now an approach. In these cases, I would do a liquid biopsy, do an aqueous urine aspirate and test it for retinoblastoma. And if you find a retinoblastoma mutation, it's a retinoblastoma. And liquid biopsy is a game changer in doing differential diagnosis between retinoblastoma and Coats disease.
And ultrasound, Professor?
No, forget it.
Okay.
You may find in old textbooks calcification is a key issue. Forget it. I've shown you some of these diffuse infiltrating retinoblastoma. None of these cases had an intraocular mass. None of these cases had calcifications. So no, ultrasound is I know this may induce a controversy, and there are some probably no. But in my opinion, ultrasound is not useful. It's not useful. No, we just don't do it anymore.
Okay. Thank you very much. Professor Brahim, you have a comment too, please?
Yes, I think Coats disease is one of the most difficult pseudoretinoblastoma cases. But there are a few things. First of all, in retinoblastoma, we have leukocoria. In Coats disease, we have xanthocoria. The appearance is more yellowish rather than whitish, which is the case in retinoblastoma. So this is the first thing we teach our residents, that they have to look to the appearance of the retina. In both cases, we might have retinal detachment. Both are exudative retinal detachment. But in retinoblastoma, it's whitish. In Coats, it's more yellowish. This is one thing. The other thing, as Professor Bornfeld just mentioned, sometimes we do fluorescein angiography, and this is with the RetCam possible. And in fluorescein angiography, we see in retinoblastoma just dilated vessels. But in Coats disease, we see telangiectatic vessels and ischemic peripheral retina. And therefore, most of the cases, by doing fluorescein angiography, it's helpful to have that tool. In addition to that, of course, the other things, but Professor Bornfeld, I had a few cases, just believe me, patients a few months old and bilateral and female, which is almost of the opposite what we teach our residents. That's usually in males, young, with Coats disease.
Yeah, we should publish that.
Yes. Yeah. So I think what we know, what we learn, that it's usually this and this. This is good to know, but for the individual case, you have to establish a proper diagnosis. So xanthocoria, fluorescein angiography, ultrasound, all of these things may help you to establish a diagnosis. And of course, if needed, a liquid biopsy, it also may facilitate your diagnosis.
Yeah. Also, we may see cases you are not sure. Xanthocoria, it's more yellow. It is, definitely. But there are exceptions for everything.
Of course.
And I think liquid biopsy is a game changer.
Of course. I agree with you.
Yeah.
Thank you very much. I have a question, Professor Bornfeld. In many countries in the Near East, they don't have access to brachytherapy.
Yeah.
For the focal retinoblastoma, small retinoblastomas. How do you think, how many percent we can spare the brachytherapy, that the doctors there just treat such cases with cryotherapy or laser therapy?
No, the cryotherapy may be used in some retinoblastoma, but you're better with brachytherapy. And you do not need too much plugs. Essentially, you need just two. You need just a small blastoma plaque and what is called a CCA plaque, and anything else is not treated with a plaque. So you need just 2 plaques. And at the end, probably it's cheaper than doing anything else.
It's not so easy. You need a physical unit. You need another setting.
Yeah, I need a physical unit, but you can do radiation calculation by yourself. It's not very complicated to do that. But brachytherapy that has been published better than doing cryo laser. And you're doing a small plaque for retinoblastoma and a CCA plaque, and that's it, 2 plaques. And you can do a lot of these cases much more safer than you would do with cryo. Yeah.
The last
you can do a cryo in a small tumor, of course. Yeah, of course. If there is a 1 millimeter tumor, you don't need a plaque. No? But if you have a tumor of, let's say, 2 or 3 or 4, even 4 millimeters, you never use a cryo. No, if it's just a small lesion of a millimeter, of course you do a cryo.
Yes, thank you. The last question I take or I get every time or frequently some cases from cots. This is from some Syria, which have a diffuse retinal detachment due to oxidations. In some cases, we done in Essen brachytherapy that's like caring and the retinal detachment.
We haven't that published. I could have shown a close with cots and that works. It's unpublished so far. Yeah.
Yes. What about your opinion? Should we? Is it a blind eye at the last? But should we do that for children we cannot
if Coats disease is a blind eye, it makes sense to look at what's published histologically on what type of retina in that eye. Yeah, there's some very courageous surgeons. You just put that retina back to the choroid, whatever it costs. But if you look at the histology on these patients, they do not have any functional retina in these eyes. These are just glial membranes. There are no receptors. There's nothing. So what you are reattaching in these eyes is a blind retina if you are a successful, courageous surgeon. And but you probably get a redetachment, another redetachment, another redetachment. And so if you just consider that retina is not a real retina which will function, I think that limits what you're doing on these patients. And they all will get a retinal redetachment. If you do surgery in these patients, remove silicone, if you use silicone, the retina will come out.
But about the indication to avoid more complications like neovascular glaucoma, literally.
In my opinion, if a patient with Coats disease has neovascular glaucoma, that eye is lost. And you should really consider if you would do that. These are children. If you just would hospitalize these children for surgery, another surgery, another surgery, another surgery, another surgery, I think these patients do better if they have a good prosthesis. Yeah.
Thank you. Professor Brahim has another comment, please. I think we have over the time. Professor Brahim?
No.
Yeah. The last a small question: how sensitive is the liquid biopsy?
It's now very sensitive. It's getting even better, and there are now better test kits, and we use it. I think we are. If there is a retinoblastoma in that eye with free DNA, it's more than 90% now.
Thank you very much. So we have answered all questions. Thank you, Mr. Professor, for your time. Not on.
It was my pleasure. It was my pleasure.